We're so excited and glad that you've joined us today for this session. The session will run about an hour and a half, and we should finish up around 2:30 Eastern time. Just a few rules of the road before we get started. You'll notice that your microphones are muted. We ask that you please keep them muted throughout this session so we can ensure that the information we hear is delivered. Sometimes I know there could be some background noise, and we would really appreciate if you could keep your microphones muted. If you do have questions for the doctors, which we hope you do, please use the chat function right at the bottom of your screen. We also have closed captioning today. To access that, just click on the closed captioning button on the bottom of the Zoom window and then select show subtitles. And again, if you have any more questions for us, please just reach us through the chat function. And with that, I'd like to introduce the CEO of the OI Foundation, Tracy Hart.
Thanks, Erica. Thanks so much, everyone, for joining us today. It's so good to see so many familiar faces. I hope you're enjoying the conference so far, and we're really anxious to get your feedback once the conference is over. And I hope you're all going to be joining us for the closing session as well, because we have some really neat things to share with you at the closing session. But my job here today is to introduce you to your moderator and facilitator, Carolyn Tipton. Carolyn is a former member of the OIF Board of Directors, a longtime volunteer, a wonderful volunteer. She served on our executive committee for a number of years. She has type 1 OI, lives in Los Angeles, California, and I'm so proud and pleased to call her my friend. So Carolyn, I'm going to turn it over to you.
Thank you, and hi to everyone. We're so happy that you could join us today for this Mild OI Forum, and we want to say a special welcome to those of you who may be joining the National Conference for the first time, and for those of you from around the globe who might be joining in. So I hope you've attended several sessions this weekend. You've probably taken in a lot of information. And today we're going to take that information and really sort of focus on how it affects those of us with mild OI. The purpose of the forum really is to get your questions answered. That's one of the things I love the most about the National Conference, is the opportunity really to ask a lot of questions and get your questions answered. So with mild OI, you know, our disorder may be considered mild, but really there's a lot of variability between individuals. Some of you may have been diagnosed as a baby, as I was, some maybe not until adulthood. Some may have had a couple of fractures, some many fractures. Sometimes this is called an invisible disorder. And so unless I have a cast or I'm using a mobility device, folks may have absolutely no idea how my OI is affecting me. So I've also noticed that our needs and concerns can really change greatly as we age. With each decade, there are new concerns and issues we face. So today we're going to cover a broad range of topics, and then give you a chance to answer, to ask all the questions that you would like. And we're going to talk about things ranging from fractures and compression fractures, pain and fatigue, to our bone health. How do we keep our bones as healthy as possible? What are the latest drug therapies? We're going to talk a bit about aging with OI and some of the psychosocial considerations of living with mild OI. And we're also going to talk about hearing loss. And we came up with these topics because we sent out a quick survey to all of you who registered. And these are some of the topics that came up. So we're going to start there, but we welcome your questions on any topic related to mild OI. And our format will be that we're going to let our doctors speak. And then if you would hold your questions until the end, we're going to have our Q&A then. But you are welcome to submit any questions at any time over the chat feature. And we're very honored to have an amazing group of doctors joining us today. I'm just going to introduce quickly, and we'll tell you a little bit more about each doctor as they present. But we're joined today by Dr. Reid Sutton, Dr. Peter Smith, Dr. Eric Orwell, Dr. Emily Germain-Lee, and Dr. David Vernick. And we're going to start with Dr. Reid and Dr. Smith, and they are going to talk about fractures and compression fractures and pain and fatigue. And Dr. Sutton is a professor of molecular and human genetics at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. And he's a member of our OIF Medical Advisory Council. Dr. Smith is an orthopedic surgeon and director of the OI clinic at Shriners Hospital in Chicago. And he is also a member of our Medical Advisory Council. So Dr. Sutton and Dr. Smith, I'll turn it over to you.
Great. Thanks, Ms. Tipton. Welcome to everyone. I'm sorry we're not getting to see each other in person and socialize, which is always such a great part of the national conference. I'm just going to give a little quick rundown and discuss pain and fatigue and vertebral compression fractures along with Dr. Peter Smith. And as Ms. Tipton said, we do want to leave plenty of time at the end for questions, so we are looking forward to those. So I just wanted to talk a little bit about pain and fatigue and general quality of life overall. So this is these are some results of a study published a couple of years ago, led by Dr. Laura Tosi at Children's National Medical Center. And this was a pilot project through the National Institutes of Health funded Brittle Bone Disease Rare Disease Clinical Research Network Consortium. And this looked at a series of patient-reported outcome tools to assess various life experiences of individuals with all types of OI, including children and adults. And we also did look a little bit, but just as since this is a mild OI symposium, to let you know, did not see a lot of difference, somewhat surprisingly, in these results between individuals with milder type 1 OI and more severe types of OI. What you can see on this graph are scores related to various domains for quality of life. You can see the red line that goes across there at 50. And so when these patient-reported outcome tools are used in the general population, the score for the general population is 50. So meaning individuals that don't have OI, that are just, otherwise generally healthy. And what we can see when we look at various domains, including things like fatigue, pain related behaviors, anxiety, depression, and sleep disturbance, individuals with OI have higher scores on those as compared to the general population. So meaning kind of more anxiety, more fatigue, more pain interference, more sleep disturbance than the general population. And conversely, when we look at physical function and social role satisfaction, you can see that those are below national population averages, meaning again, less satisfaction for individuals with OI on their kind of peer or social interactions, and less satisfaction in regard to their physical function. So again, I think obviously probably not news to a lot of people with OI, but again, is important in really kind of clearly demonstrating these domains. And again, hopefully moving forward, we're planning to try to look at various outcomes related to these to develop interventions to address these significant issues in individuals with osteogenesis imperfecta. So as you know, kind of pain can be both what we call acute, which is kind of immediate pain or pain like associated with a fracture, but also chronic pain can occur without a fracture. And both of these types of pain can be significant in mild OI. We also know that increased pain and fatigue that we saw demonstrated on the previous slide are associated with reduced quality of life. And when we're talking about assessing pain, it's important to look at a variety of domains. So what's the type of pain? Again, is it kind of what we would call acute pain? Is it chronic pain? Is it sharp? Is it dull? Does it feel like electrical things shooting down the arm or leg? Where is the location? Obviously is important for pain. The frequency, including things like, is it all day? Is it a couple of times a week? Is it more in the morning, more in the evening? All of these things are important in communicating with your healthcare team. And then finally, things that we call aggravating or alleviating factors. So what things make the pain worse or bring the pain on, and what things reduce the pain or help that individuals are doing. And all of these, again, are going to be important in developing a plan to manage pain. So typically, we would recommend starting with the least invasive or least risky things first. And these would include things like stretching, working with a physical therapist, things like yoga or other sorts of things to increase mobility and keep things active. These things can also help distract from pain through activity and help reduce pain, we know. Again, alternate sensations like warming or rubbing can also help our body perceive pain differently and distract itself from pain. So these are important, easy and low risk things to try. And then again, things that are, can help reduce the pain are things like self-hypnosis or meditation, biofeedback, relaxation, again, other things that help distract from the pain. In children, again, kind of games or other sorts of things can also often be helpful. When those things don't work, or when those things don't completely reach an individual's goals for managing their pain, we can move on to medications. Again, we would start with the things that are the least risky, like non-steroidal anti-inflammatory agents that can either be over-the-counter, or again, if the over-the-counter medications like that don't work, there are prescription non-steroidal anti-inflammatories or other non-narcotic prescriptions that can be helpful. Intravenous bisphosphonates can be good for pain. I have a number of individuals with type 1 OI who maybe don't have a lot of fractures, but they do have a lot of pain, and it often seems to be kind of foot or leg pain, sometimes back pain, that is again inadequately managed by these other medications or interventions that I've mentioned so far. And in these sorts of situations, I would try an intravenous bisphosphonate, such as pamidronate, to see if that helps manage the pain. And again, often individuals will get significant pain reduction with pamidronate that can last for a number of months. That medication, again, can be given cyclically every few months to manage pain. One of the things, particularly with acute pain, is that when you have a fracture, you can also have a muscle spasms associated with fracture, as well as anxiety, because you know that if somebody bumps your, broken arm or leg, or you accidentally move it, or those sorts of things, that it's going to be painful. And so a class of medications called benzodiazepines, Valium is an example probably most people have heard of. That's very good to treat muscle spasms and anxiety. And so again, if it's that sort of acute pain, I found that Valium can often be helpful. And again, generally is, other than making people a bit sleepy, is generally quite well tolerated. Some individuals require narcotics for adequate pain management. I typically try to reserve these as a last resort because there are lots of side effects associated with most of the narcotics, including things like constipation, dizziness, sleepiness, and then of course, they can be addictive. And again, we want to try to avoid using those, particularly for chronic pain when we can. If it's short term for acute pain, again, while there are these side effects, if like constipation, if managed appropriately, should really not be addictive for acute pain, but again, chronic pain certainly can be. Sometimes it's helpful for individuals to keep a pain diary, and so that would be some sort of little calendar where you record either kind of every day or once a week or a couple of times a week, kind of your level of pain and how you're feeling and doing with that. And that can particularly be helpful when we're trying different interventions to be able to look back and see, oh yeah, you know, on a scale of 1 to 10, before I started, doing yoga, I was consistently at a 6. And now that I've been doing yoga for, 3 months, the pain is generally down around a 3. So knowing kind of what's helping over time can be good for a pain diary. And then again, working with your orthopedic surgeon or anesthesiologist, whomever it is, again, to have a plan, particularly for acute pain due to fractures. Moving on to vertebral compression fractures. So over on the right-hand side of the slide, you can see 2 spine x-rays that are taken from the side. The far right image is a pretty normal looking spine. And you can see, hopefully people can see my pointer. These are called the vertebral bodies, these kind of rectangular things that you see here on the spine image. This is an individual over here with type 1 OI, and you can see that there are a number of those vertebrae that have a concave shape to them or kind of collapsed there. And so that again, those blue arrows are pointing to vertebral compression fractures. And you can see this individual has multiple vertebral compression fractures throughout the spine, the thoracic spine and the lumbar spine. The cause of vertebral compression fractures can either be low bone density or can be secondary to trauma, like jumping from a height and landing on your feet that can result in a vertebral compression fracture. While vertebral compression fractures can cause back pain, actually the majority of individuals with vertebral compression fractures don't have any symptoms at all. And we know again that individuals with OI, including mild or type 1 OI, have a fairly high rate of vertebral compression fractures. And so we believe it's important to screen for these with x-rays and not just rely upon pain, since many individuals don't have pain. Complications from vertebral compression fractures include scoliosis or curvature of the spine or a bent spine. So when you see older individuals that are kind of humpbacked or hump-shouldered, that often is due to vertebral compression fractures and loss of the height of the vertebrae. In regards to treatment, and then I've highlighted it here with the asterisk prevention, because ideally that's what we would like to do, is prevent vertebral compression fractures from happening rather than try to treat them once they've already occurred. If you're having pain, again, the pain management things that I had discussed, exercise and stretching are helpful. Again, activity or having muscles kind of pull on bones stimulates bones to grow and to increase their density and strength. So exercise is important. diets and supplements, so making sure that you've got adequate amount of calcium and vitamin D in your diet, or if not, to take a supplement. Again, bisphosphonates can be used to treat vertebral compression fractures, and there's some evidence in children that this can actually heal vertebral compression fractures. I think generally, and I'm going to let Dr. Smith jump in here too, please, but I think in general, most of the time, my experience is that our orthopedic surgeons don't typically recommend bracing or other sorts of surgical management. But again, I think Dr. Smith's going to have some helpful tips as well.
Yeah, thanks. I think that's a wonderful review. And these are things that typically in the past we found on the X-rays, and but there are some spine fractures that are acute, where there's acute pain and maybe some abdominal symptoms. So those you can sort out a little bit separately from these other non-acute things that you're finding on the X-ray. With closer questioning, though, some of those up in the thoracic area will be associated with some achiness or pain upon questioning. So I agree completely that these are not generally surgical. Most people think of a spine fracture as being an emergency or things like that. The incidence of burst fractures where the spine is actually unstable are very rare in OI. They do occur, mostly in relation to trauma. But these other events are basically a harbinger or the sign that of the osteoporosis that's present, or the poor bone quality. And we can see them now in children. We're looking very closely for those because we think that's possibly a sign that the spine is going to be in trouble later on. With back pain and things like that. So many of us are using that as a way to screen for children with mild OI that might benefit from bisphosphonates. This is an area that's under investigation. It's by no means proven, but in general, children that are having these compression fractures, many of us are treating them now with the bisphosphonates, especially if it's in association with a low bone density. And of course, we're recommending these other things that Reid's been talking about, the tremendous importance of exercise, building up the abdominal muscles to support the back. All those are general principles that are the most important thing in children and also in adults. You wanted me to comment on bracing. Bracing is only useful for people that need to get over help them get out of bed. And sometimes I'll use a corset or a chair back brace for what I think is an acute fracture. But I think it's important to try to get people mobilized and out of bed to keep moving. These are not surgical fractures.
Great, thanks so much. So those are all the slides I have. So Ms. Tipton, I'll turn it back over to you.
Thank you, Dr. Sutton and Dr. Smith. We really appreciate that. So now we're going to turn our attention to bone health and the new drug therapies with Dr. Eric Orwell. And Dr. Orwell is a professor of medicine in the Division of Endocrinology, Diabetes, and Clinical Nutrition at the School of Medicine at Oregon Health and Science University in Portland. Thank you, and we'll ask everyone to remember to hold their questions to the end. Please put your questions in chat, and we'll take it away, Dr. Orwell. Thank you.
Thanks very much. It's exciting to be part of the forum this morning. Drs. Smith and Sutton have introduced the idea of
Excuse me, Dr.
fractures. And
there we go.
Got it, yeah. Have introduced the idea of fractures and what we might do about it. My job is to expand on the treatments that might be available to prevent future fractures. I'm an adult endocrinologist and am most competent in discussing treatments in adults, although I'll also present some information about doing so in kids. I'll show some slides. They'll go by pretty quickly, but they're meant to introduce the issues, and we can come back to them with questions. So the first slide is to emphasize the fact that treatment in OI is multidisciplinary. And although I'll concentrate on the fracture issue, this really should be a team effort. And a variety of other parts of the team can really help with the fracture prevention issue as well. There are some basic bone health issues to cover before we talk about treatment. Again, Dr. Sutton brought up the issue of nutrition, and vitamin D is a key part of that. What I show here are the recommendations for minimum vitamin D intake from the National Institutes of Health as a function of age. And you can see that it ranges from 400 international units a day in infants up to 800 international units a day in older adults.
Pardon the interruption, Dr. Orwell. Could we ask you to change the view to presentation view?
Yeah, I'll do that.
Thank you.
Let's see if I can do that. Do you see it appropriately now?
No, you'll need to share your screen once more and then we should see it.
Okay. How's that?
Perfect, thank you.
Okay, so vitamin D again. I usually recommend 1,000 international units a day in adults. That should be sufficient in people who are otherwise nutritionally competent. But at the bottom, I emphasize that particularly in people with OI, it's important to measure vitamin D levels in the blood. Some people may need larger amounts of vitamin D, and measuring vitamin D levels is a good way to know whether the vitamin D supplement that you're taking is sufficient. Calcium is another issue that's very important for basic bone health. And again, from the recommendations from the Institute of Medicine here, you can see that the amounts of calcium intake vary from those in infants to those in older people. These are probably very appropriate for OI. And there are a variety of ways that you can investigate how much calcium is in your diet and how much calcium supplements might be appropriate to supplement the diet. So again, calcium, vitamin D, two important elements of basic bone health. And the third is physical activity. Again, Dr. Sutton and Smith emphasized the importance of physical activity when you're dealing with vertebral fractures, but physical activity is very important for maintaining bone health, bone strength, bone density, reducing falls. Again, weight bearing is probably the most important element of physical activity. And there are a variety of ways to achieve adequate exercise for bone health. Consultation with physical therapy is frequently very useful for designing an individualized program. So the three basic elements of bone health: vitamin D, calcium, and exercise. In some people, drugs are also helpful and necessary. And here I show all the drugs that are available and some that are coming. for the reduction of fracture risk in people with OI. Although, of course, there's not enough information about OI, but there is enough so that we can make some basic recommendations. The first on the list are the bisphosphonates. They've been around the longest, and there's most experience with them. They come in oral forms like alendronate or Fosamax, Actonel, Boniva, and IV forms like zoledronic acid or pamidronate. We can talk a bit more about that in the question and answer session, and I'll show some slides about strategies for deciding when drugs are useful. Denosumab, a newer drug, trade name is Prolia, not a lot of experience yet with Prolia in OI, but an interesting drug because it not only reduces bone breakdown, which is how the bisphosphonates work, but also allows bone formation to proceed as well. Very useful in people with osteoporosis, and we're just gaining experience with it in OI. Teriparatide or Forteo and abaloparatide or Tymlos are drugs that stimulate bone formation. So they work in a different way than the bisphosphonates or Prolia. They can't be used in kids, but in some people, some adults with OI, particularly type 1, they might have a very useful role. And then finally, romosozumab or Evenity, a brand new drug on the market for osteoporosis. A lot of interest in whether it might be useful in OI. Again, a bone forming drug. Not a lot of experience yet with it in OI. And setrusumab, a research drug that looks like in early experience it might be appropriate or useful in OI. We'll be hearing more about that. So the point here is there are a variety of options, and as I'll emphasize later, the choice of what drug that might be appropriate is a very individualized decision made between patients and their physicians. I show here a scheme for deciding how to think about therapy in kids with OI. And this is from the group at Shriners in Montreal, which has had a lot of experience. It's complicated, but I'll summarize it by saying the choice of going with a drug therapy in kids with type 1 OI is all about fracture risk. In kids with type 1 OI who have not had fractures, particularly vertebral or long bone fractures, it may be appropriate not to use drugs. However, in kids who have had fractures, drugs may well be appropriate. And this scheme uses zoledronate and goes through a process by which you decide whether to use a drug, you decide what dose to use on the basis of whether the kid is still growing and what the bone density is doing. You decide to continue the drug and at what dose, and usually drugs are stopped when growth has ceased, so at the end of puberty. Again, a very individualized approach using an IV bisphosphonate, in this case reclassed. And the key issues are there fractures? Are fractures continuing? What's the bone density? And is the child still growing? A similar process in adults to decide about whether drugs are appropriate. It's all about what is the risk of additional fractures. And key decision-making points here are the fracture history. Have there been recent fractures? And if so, one might be much more interested in using drugs to prevent additional fractures. Bone density measurements are important. The lower the bone density, the more concern there may be and the more that drugs may be appropriate. Is bone density falling, which obviously we don't want to see. And in that situation, drugs might be more appropriate. And finally, are there additional risk factors that might increase the likelihood of fractures? Menopause is an important time in women and is usually associated with the decline in bone density and should be one of heightened concern in people with OI. People who are older than age 65 are at increased risk of fractures because of their age, and in those with OI, that might increase the interest in drug therapy. Other medical conditions or medications that increase the risk of fractures, and patients who are at increased risk of falls. All these might be more likely to consider drug therapy. The choice of which drug is very much an individual decision and has to do with how aggressive one wants to be, things like adverse events and their likelihood, what's attractive to the individual patient in terms of how they want the drug administered. So there's a number of options, and it's an important discussion that requires both patient and clinician input. Side effects are important. All drugs have side effects, of course, and the decision to undertake drug therapy really is about the equation between benefits and risks. Most of these drugs are very safe, but it's an important discussion to have whenever you're considering drug therapy. Is the benefit of the drug greater than the risk of adverse effects? And again, this gets back to the issue of how likely fractures are and how important it is to be aggressive in reducing that risk. And finally, the question frequently comes up about how long treatment should go on. And this is, again, a very individual decision. In some patients, drug therapy is undertaken and the effect is excellent. Fracture risk is reduced, bone density is increased, and the decision may well be appropriate to discontinue therapy. In other patients, the risk of fracture continues to be high, and drug therapy for a longer period of time may be appropriate. So with my patients, every year when we get together to discuss the strategy going forward, we have a discussion about whether therapy should be continued, what's the fracture risk, what's the bone density, and we go from there. So hopefully that's been a useful brief overview, and we'll get back to questions later on. Thanks.
Perfect. Thank you so much, Dr. Orwell. Next, we have Dr. Emily Germain-Lee. Dr. Germain-Lee is a professor at the Department of Pediatrics at the University of Connecticut School of Medicine. She's the chief of the Division of Pediatric Endocrinology and Diabetes at Connecticut Children's Hospital. She's director of the Center for Rare Bone Disorders, and she's co-director of their OI Center. And Dr. Germain-Lee is going to talk about aging with OI, which I know is something that's very important to all of us, and also a bit about the psychosocial considerations of living with OI. Dr. Germain-Lee?
Thank you, Carolyn. Let me share my screen. Make sure everyone can see that.
Looks great, thank you.
So I just want to say Dr. Sutton and Dr. Orwell really gave an excellent backdrop to what I'm going to be talking about. So one thing I want to just mention in terms of aging with OI, I'm a pediatric endocrinologist, so you may wonder why I'd be talking on this. But one thing that I found over the past couple decades in treating OI in children is that when they get to the transition of care at adolescence, usually around 18, it's a very difficult time to try to find adult care, at least in the area in which I'm practicing. And over the years, I started to see patients through their adult lives as well. And had the benefit of also working with Dr. Jay Shapiro, who was an adult endocrinologist, to gain knowledge in this over time. And so I just wanted to follow up in this because what I noticed too is from parents at least that it's even harder when one's diagnosed as an adult to go out there and try to find a multidisciplinary team. And as both Dr. Sutton and Dr. Orwell said, the multidisciplinary team is really, really important. And I think what's happened is there is a greater awareness now of the appropriate transition. The OI Foundation has a great handout online about what you need to think about in this transition. And you need to start developing the team early. And this team needs to be thought about at every step of adult life as one is aging. And so Dr. Shapiro and I published about 8 years ago or so the 4 main goals to keep in mind when you're developing this team. This is especially for children when they're transitioning to adulthood. The most important is you really want to maintain your current state of health and not have gaps in care. And you want to preserve or even improve your level of functioning as the demands change and or increase. For example, it's no longer going to be just school. It's going to be having a family. It's going to be having a job, a career. What's really necessary is to plan ahead for continuity of medical and surgical care. And we found that this can take oftentimes a year to really get this set up in place so everything is safe. And restructuring your support systems over time as the needs change during aging. Because as one gets past the time of working, the needs as an elderly patient are quite different than as a young adult. So what I want to touch on, as everyone has talked about, in the mild form, there can be great variability. This was even mentioned by Carolyn right at the beginning. As Carolyn said and others, you may not even know you have this until in adulthood. This can be that mild. It is in this realm of, quote, invisible disorders that has many disorders within it, not only OI, but for example, lupus and other disorders in which one may appear fine, but there's underlying chronic pain. The lifestyle and activities are definitely modified because of a fear of fracture or because of arthritis, for example. And there are greater health concerns that are underlying this. And it's not always mild in terms of fractures. I and everyone else who spoke has seen fractures that can have a wide range from being mild and just a few to being quite severe and numerous. And in terms of these fractures, most occur in childhood before puberty, then they slow down, and then they recur when one gets older. And this is a fairly reproducible pattern in a lot of patients. And of course, there's a worsening risk of fractures that occur with women after menopause, any women, once there's decreased estrogen, but in OI in particular, this will be seen. And then with men during aging, and after about 50 years of age, this starts and then progressively gets worse with age. And so the other physicians have spoken about monitoring bone densities. It can be so mild that perhaps every 2 years is fine, but may be more frequent if there's significant issues, such as yearly. And I'm not getting into treatments because that was really explained really nicely by Dr. Orwell already. So really, the goal is to avoid fall risk, as has been mentioned, any activities that could lead to fracture, and recovery is overall harder with aging. for anybody. When one ages, muscles start to atrophy in anybody. The bones start to become more fragile in anybody. So in type 1 OI, in mild OI, if there's a fracture, with every fracture, there's some immobility, and then that leads to even more decrease in bone density. So one has to keep that in mind too. And this is just a repeat of what Dr. Sutton and Orwell mentioned, that the multidisciplinary approach is key. So I also want to point out another huge issue that I and everyone sees in mild type 1, in mild OI, which is joint laxity or loose joints. Shoulder and elbow dislocations, for example, can be common. As a young child, of course, the patients are very flexible, can do a lot of really amazing things with their joints, but this really ends up being an issue as patients age. It can lead to arthritis, and sometimes the arthritis can be even more of an issue than the fracturing in terms of pain. And the laxity of tendons can also lead to muscle weakness. So as the others have mentioned, what's very important is exercise within one's limits, a preventative method of building muscular strength, because this builds the muscle-bone interactions. As muscles pull on bone, that helps increase bone density. And I just have a minor point in here. I want to just throw in swimming and water therapy. Although those aren't weight-bearing exercises, they can really be helpful in terms of maintaining muscle strength. They're very easy on the joints. It's a gravity-free situation. Very little fracture risk, of course, and so I'm a big proponent of this in order to maintain muscle strength. And as others have mentioned, physical therapy is very important, not only baseline to get some tidbits on what are good exercises for you in particular, given your degree of OI, but also very important in injury recovery. I want to touch on pulmonary just because this can be one of the more important issues. So the pulmonary system is important to monitor even in mild OI, especially so with the shorter stature, with scoliosis, especially is significant, and if one has a barrel-shaped chest, which can sometimes occur. And pulmonary function tests, I advise at least every 2 to 3 years, even if you think you have no issues. Each physician has a different timeline, but these can be subtle and you do want to know about them. And if there are issues, you need to be very careful and in fact aggressive in responding to respiratory infections. And this is very key now in our pandemic age right now with COVID. It's a scary time for everybody, and especially people who have diminished pulmonary function. So getting influenza shots yearly is incredibly important, keeping up with your pneumonia vaccinations, and as I said, COVID's a big concern. And for all forms of OI, even the mild forms, pulmonary issues can be actually the major cause of the reason for hospitalization. And if one has asthma or chronic obstructive pulmonary disease, and you have any restriction in pulmonary function, those can also be worse and lead to an increased need for medications. So what are some other issues? I'm going to just touch on these briefly. Easy bruising can occur at all ages, but it worsens with aging anyway. So in type 1 OI, it can be even more of an issue. And then of course, medications that people take when they're older, such as low dose aspirin, etc., anticoagulants, this can make that bruising a significant issue. Scoliosis has been really talked about extensively already, as same with vertebral fractures. I really have nothing to add on this. Everything's been detailed so nicely, but I do want to mention, I've seen quite a bit of issues with lifting, where people don't use proper techniques for lifting and then will have a fracture. Of course, dentinogenesis imperfecta is possible, and you're going to hear about in the next talk hearing impairments. I'm just going to touch on height. As a pediatric endocrinologist, we follow this closely. And this is a study I did with Dr. Shapiro a few years ago. And just looking at the bottom slide, that's in the different types of OI in adults. And you can see that it's listed by type. And basically at the top here is just average height. This line going across is average height. So you can see type 1 patients are a little bit below average and not as severely impaired in terms of height as type 3 or 4. But if you're from a short family, that little bit of decrease in height can lead to issues with activities of daily living. So I just want to point that out as well. So overall, maintenance of your health is what's truly key. This is key to anybody when they're aging. And really all of us take it for granted that we need to maintain a healthy diet and exercise. This is even more so in OI. And so for the mild forms of OI, really maintaining an annual physical where all systems are checked, pain is assessed so that pain doesn't get ahead of it. Self, diets assessed. I think it was detailed really nicely by Dr. Orwell in terms of what you need for calcium and vitamin D. And then I mentioned muscle strength and the pulmonary issues. With cardiovascular, there can be valvular disease, dilated aorta, so I'll talk about that in the next slide briefly. Kidney stones can be an issue, as in any condition in which there's osteoporosis and any bone degradation. Reflux, an issue in any adult, a little bit more prevalent in OI. And I'll touch on vision issues because there can be, for example, an increased risk of glaucoma. In terms of testing, the bone density has been detailed already nicely. An echocardiogram I advise in adulthood, usually early adulthood, to get at least a baseline to assess the valve, look at the valves carefully, a baseline pulmonary artery pressure, and then you follow as appropriate. Some people have no issues with mild OI, others do. The lab tests, I would say, have to be done as per your specific scenario, but I do want to mention as an endocrinologist that just like in anyone who's aging, metabolic issues such as diabetes, high cholesterol become more and more of an issue as you age. And so I do recommend that with your internist or endocrinologist, these parameters are followed. And in addition, thyroid function tests. And already calcium and vitamin D have been mentioned. Increased needs with pregnancy and breastfeeding, as was shown in the chart by Dr. Orwell, increased, and also just an importance of keeping on top of this with aging. And I want to stress that one should feel comfortable getting consults as needed. I think second opinions are always a great thing. And sometimes, at least my patients feel hesitant to do that. And I think it's good to always get another perspective and also to search out specialists that may be not a part of your team who you'd like to be a part of your team. And so I'm going to end with just 2 slides on psychosocial considerations. As I mentioned, one may look fine on the outside, but be dealing with a lot of pain and other medical issues that are hidden. And although it's great to not maybe be noticed on the outside as having issues in terms of self-esteem and drawing attention to oneself, which is something that is a concern with a lot of disorders, but the double-edged sword of this is that people sometimes don't understand that you actually do have a lot of pain and fears of fracturing going on inside of your head and inside your body. There are concerns about life at school and at work. You know, with the kids, of course, can they do things at recess? But this with aging is really a real concern. You know, will I be able to be independent the older I get? What will happen? It's going to be harder for me to recover from every fracture. What about my job? Will I be able to handle it? What about job security if people find out? Even though there shouldn't be discrimination, and I think things have progressed incredibly in this regard, a lot of places are still quite backward when it comes to looking at people within their workforce and concomitant illnesses. Then there's the concern about life at home. Will your partner understand? And what I see a lot is, will my child or children have OI? I see families, where I'm seeing both the parent and the child, and there can be a lot of guilt issues among the parents as well. So there are precautions that one has to always be aware of. Physical precautions of staying safe, not falling, not fracturing. Emotional precautions of making sure that you have the right emotional support systems, which are important to anybody, but especially if you're going to be vulnerable at some point in your life due to a fracture or pain. And then socially, as children, they need to tell their teachers, and certain people need to know, their caretakers, but what do you do as an adult? Who do you tell? Will it affect your job? And there's a recent study I just want to mention that I thought was really well done by Simikalis et al. It was out of Dr. Rausch's group a few years ago, where they identified 6 social themes. And it was really beautifully written, a review of many of the psychosocial studies. So of course, there's this feeling of isolation and feeling different, and this underlying fear of fractures. So those are 2 of the main themes in OI, even the mild form. But there's coping with challenges that occurs if you have it from a young age, starts very early. And if you develop it in adulthood, it starts then, but you learn to start to cope with challenges. And coping with challenges is very time consuming and it's energy consuming. But what happens is with the coping with challenges, the patients found that they indeed found a lot of inner strength and developed a lot of very positive coping skills. And that they also adapted to new situations easier. They learned new skills because of the OI and the restrictions placed upon them, and they learned to adapt to this. So there was a slight silver lining to some of the underlying pain and difficulties leading a life with OI. Social relationships, although initially one may think that they could be impacted because one would be treated differently, ended up being something that were really well developed in the OI community. And patients with OI really learn to build up social relationships with supportive people in their lives, whether they be family, friends, or colleagues. And finally, a focus on intellectual feats. And this most likely was hypothesized to be from the fact that because certain physical skills are limited, certain sports are limited, intellectual feats tend to be focused on, but a real, really an accentuation in this population of developing academic and career skills that take them into the future and lead them quite far in life. So I'm going to end there, and I know there'll be questions at the end, but I think the OI Foundation's website does a wonderful job of dealing with many of the issues of aging as well as the psychosocial issues. And I want to thank you for listening.
Thank you so much, Dr. Germain-Lee. That was packed with a lot of information. Our last presentation is on a topic that I know affects a lot of us, and that's hearing loss. So I'd like to introduce Dr. David Vernick. He is a surgeon in Otolaryngology, that's always hard for me to say, at Massachusetts Eye and Ear Infirmary and the Beth Israel Deaconess Medical Center, Brigham and Williams Hospital, and Children's Hospital, all in Boston. And Dr. Vernick is also on our Medical Advisory Council. So Dr. Vernick?
Thank you very much. Let me see if I can do this right and share the screen. I'm clicking it. But it doesn't seem to be, hang on, maybe that's working. Oh, maybe it's working.
Here we go. Perfect.
Are we all set here?
Yes, thank you.
Great, thank you. And good morning for you out west and good afternoon for you who are not. I'm going to just do a brief run through here on hearing loss in OI and try and just give you a little bit of background so you can understand why you're at greater risk for having hearing loss, and that risk increases as we get older. And if I can, there we go. Just a quick picture. If you can see my pointer here, the ear is a quick anatomy lesson. This is the ear that we hang our masks on now with our little straps. Our ear canal, our eardrum, 3 little bones of hearing in the middle ear, and our inner ear, which have our hearing organs and our balance organs, and then the nerves that take all that sound to the brain. This part from the eardrum, the little bones of hearing in the outer ear canal is called gives us our conductive part of our hearing loss, and the part on the inside gives us our nerve loss. And so when we look at people who have hearing loss, unfortunately, people who have OI have troubles on both the conductive portion of their hearing system and the sensory nerve portion of their hearing system. Just a quick look at a hearing test, and one of the ways to find out how much hearing loss you have is to get a hearing test. And the different sounds go through different frequencies. So these go from the bass frequencies up to the high frequencies, or the bass up to the soprano. And the smaller the number, the better the hearing. So we measure how much sound it takes for somebody to hear. And if you look at one of these hearing tests, we divide it into different segments. So normal hearing is usually 20 to 25 decibels or better, mild to moderate, severe, and then profound. And we deal with each one of these with different ways, but usually when you start getting into the mild to moderate, we start thinking about hearing aids. And then when we start getting into the profound hearing loss, we start thinking about something called cochlear implants. This is just a typical hearing test of somebody, whether they have OI or not. In the low frequencies, most of us do much better than we do in the high frequencies. Hearing loss from aging affects us in our high frequencies. Hearing loss from things like noise exposure and head injuries and infections usually affect our high frequencies more. So we tend to lose high frequencies. The low frequencies are mostly vowels. The high frequencies are more of our consonants. So when we start losing our consonants because of background noise, we start losing the beginnings and endings of words, and we start having trouble understanding, especially when there's background noise, like noisy restaurants, if we ever get back into them, or in bigger groups, or if the TV's on and somebody's trying to talk to you, or they're in the other room and they're trying to talk to you and shouting through, and you can hear them, but you won't understand them because you're missing the beginnings and endings of the words. So you're missing the consonants. There are a lot of things which can affect our hearing, and most of these are not specific for OI. Aging, we all lose our hearing as we get older. Bad head injuries, loud noise exposure, infections, drugs, especially some of the chemotherapy drugs that we get for cancers, some of the intravenous antibiotics we get for life-threatening infections, strokes, and there's a whole bunch more I could add in that are little tumors and things like that, which are not quite as frequent, but there are lots of causes of hearing loss. But in OI, we're much more susceptible to having hearing loss, and I'll show you a couple of slides in just a minute to try and picture, so you can picture that and understand exactly why. 50% of the people over 50 have a handicapping hearing loss with OI. That's really a significant number because that's significantly higher than the normal population. And this means that 50% of the people are going to need hearing aids or hearing assistance by the time they reach 50. The loss is progressive, and it's true in all of us that our hearing loss is progressive, but it's more rapidly progressive in those with OI. And that's why it's such a high percentage. The reasons that we lose the hearing are the same as everybody else's, and a few other bonus options. One is we have weakened bone structure in our ears, and another one is that we have abnormal inner ear environment so that that OI bone doesn't support our inner ear as well. And that's what I'm going to show you a couple of slides. This is a normal stapes bone. This is the smallest bone in our body, and it's one of the 3 bones that we have in our inner ear. There's the malleus, incus, and stapes, or hammer, anvil, and stirrup, and this one as you might guess, is the syrup. And this is actually a patient who had OI, and this is their stapes. And if you look at it, the bone structure is irregular. There are some places where the bone doesn't look so good. There are places where there have been fractures. Here's another fracture spot right here, another fracture spot right here, and here's a little piece of bone that got dislocated. It's not clear what caused this one, but it could have been as much as a loud noise exposure, because this bone gets very fragile. So when we do things to try and repair it, we're not working on a bone that looks like a normal stapes bone. We're working on something that is significantly less solid, can handle far fewer stresses. And if we look at the temple bone, this is not to make you a histology specialist. I just want to show you, this is the temple bone, which is the part of the head that holds the inner ear. This is an OI temple bone, and you can see the bone here. This is a normal temple bone, and look at the difference in the texture of this bone compared to this bone. This bone over here, the normal bone, supplies a very unique environment for this inner ear to live in. This bone is not quite as good supplying as good an environment. And so you can look at it and say, if you don't live in as good of environment as others, your inner ear is not going to survive as well. And so things like trauma, things like noise exposure, things like infections, things like just the environment around here cause a lot more damage to the inner ear at a lot earlier age than it does in somebody who has a normal bone. There are treatments for hearing loss. Most of them are the same treatments that we have for anybody else. Bisphosphonates have been touted as potential. The only study that ever showed any benefit for hearing was a very small study, which has not been replicated over the last few years, to see if third-generation bisphosphonates actually helped stabilize or improve hearing in an ear. I will tell you that that is not clear at this point, and nobody I know recommends taking bisphosphonates to prevent progressive hearing loss. Everybody who has hearing loss, hearing aids have improved, and they've improved dramatically over the years. They're not our parents or our grandparents' hearing aids anymore. They're digital now, they're Bluetooth capable by and large, and now they're even rechargeable. So as we get older and we have difficulties changing those little teeny tiny batteries, we don't have to worry about that anymore. We can just plug it into our nightstand when we go to bed, and in the morning it's recharged. Significant improvement if you have any kinds of dexterity issues. There are surgery that can be done for people who have OI to try and prevent or try and help things like that stapes bone that we just looked at that didn't look so healthy. The problem with surgery in somebody who has OI is that you're attaching reconstruction to bone that is not any better or any healthier than the bone that you're trying to replace. And so the success rate of stapedectomies, which we're replacing that little bone, is nowhere near as good as it is in somebody who doesn't have it, although it's reasonable operation, but it doesn't prevent the nerve hearing loss that you get, so that even if you have a successful stapedectomy, you're still going to be in that 50% over 50 who's going to need hearing aids. Cochlear implants is something that has been developed over the years for people that are deaf, and occasionally people will go deaf from all kinds of causes, but osteogenesis imperfecta is one of those. So there have been a number of people who have gotten cochlear implants with OI, and they're very successful. The thing that you just have to remember is that that bone that is surrounding the cochlea is not as solid a bone as normal bone, and so the settings for the cochlear implants has to be turned down a lot to take that into account. There is new research being done now in a number of different fronts on trying to regenerate the inner ear. I wouldn't hold my breath at this point unless you're really young, that's going to be something that's going to be available in our lifetime. But there's a lot of breakthroughs that are occurring in how we're treating things and our modification of genetics. And hopefully that will be something in the future to restore the damaged structures that we have. Old hearing aids That's 1938. They were great big. They keep getting smaller. They keep getting smaller and smaller. And then there are things like assistive listening devices, which if you're using hearing aids, you may find very beneficial. There's telephones that have text on them, which are very helpful if you're having trouble hearing. There are things called TV ears, which can turn the volume up in your hearing for your TV, and your spouse or your kids that are around you don't have to have it blasting, so you can hear separately. And there are a lot of other bells and whistles so that the alarms in your house, your doorbells, your smoke detectors, your CO2 detectors and all can sound alarms even into your hearing aids, or even loudly, or vibrate your bed to wake you up at night if there are problems. Most of the hearing aids now we have are Bluetooth and can be hooked up to a lot of these assistive listening devices as well, which really makes a huge difference in how we hear. This I just stuck into, people ask about a cochlear implant. It's a piece that's threaded into the inner ear itself to stimulate the nerve directly and bypass all this abnormal structure. And a little piece that looks like a big hearing aid that's worn on the outside that will stimulate the inner part, so that if you are deaf, you can now rejoin the hearing population. I want to thank you. I hope you're all staying safe. I look forward to seeing you all in a future conference. Have a great day. Thank you.
Thank you, Dr. Vernick, and to all the doctors. That's a lot of really great information for us. And so thank you all for your patience on questions. We're going to try to get as many in as we can. Do we have, let's see, should we start with orthopedics now or no? Erica?
Yes, that would be great.
Okay, perfect. So one question is, is chiropractic safe and possible for OI, and is it beneficial? Any thoughts on that?
Dr. Smith is unmuting. Okay, I think we're having a technical difficulty. If we could skip down to a different question.
No worries. I'll tell you, let's just move to some bone drug questions. There's a question of several people covered the vitamins and supplements that are important, calcium, vitamin D. The question is about a little bit more explanation about calcium and kidney stones. And then also, do you find magnesium helpful? And then finally, as part of that question, keeping our immunity strong is important all the time, but especially important now during COVID. And is there anything you would say we should add to boost our immunity during this time?
So let me start out with some of those. There's a lot of questions in there.
I know, sorry about that.
Yeah, no problem. So the calcium and kidney stone issue is an important one, and increasing the amount of calcium in the diet can increase the amount of calcium in the urine, which is an important contributor to the kidney stones. So if someone has had kidney stones or has a family history of kidney stones, I think evaluating the urine would be very important, and that would help to decide how much calcium intake would be appropriate, and to follow the amount of calcium in the urine if calcium supplements are used. The recommendation is not to avoid calcium if one has kidney stones, because obviously calcium is important for bones, but rather to use urine measurements to help make sure that the amount of calcium that's in the diet or in supplements is not too much. This is an issue that should be discussed between the patient and the clinician. In terms of magnesium, magnesium is important for bone. Most people who have normal nutrition don't need magnesium supplements. There are some individuals who, for instance, have malabsorption or other GI disturbances that might need supplemental magnesium. Usually it's not necessary. Magnesium supplements wouldn't be harmful, but again, there isn't good evidence that magnesium makes a big difference. In terms of supplements to boost immunity, that's not something that I'm terribly familiar with, so I'm going to punt that to some of the other experts if anybody has opinions.
Anybody like to weigh in on that? No, let me move on to one more question for Dr. Orwell, and this is related to dental issues and drug choices. And this is a side note for everyone. Dental issues are something that I know a lot of us face, and we're not touching on that in this session because there is another separate dental session later this afternoon that you may want to check out. But in terms of that, and even those of us who haven't been diagnosed with DI, with Dentogenesis imperfecta, do as we age tend to have more dental issues. How does that affect what bone drugs might be best for us, or does it?
So I think at the heart of the problem is a rare side effect of several of the drugs that are used to prevent fractures, and that's called osteonecrosis of the jaw. It is associated with the bisphosphonates and with prolia. It's a condition in which a part of the jaw bone dies. It's usually easily detectable in its early stages by the appearance of an ulcer or pain or difficulty healing after a dental procedure. Again, it's very, very rare in people who take this drug. Think 1 in 5,000 or 1 in 10,000 people. Nevertheless, it is an adverse effect and should be part of the discussion whenever someone decides or is deciding to take a drug or which drug to take. Dental examinations are important in people who are taking these drugs. Importantly, there doesn't seem to be an increased risk of these things in people with OI. And obviously, Dentogenesis imperfecta increases the concern about dental issues in OI, but there does not, at this point, seem to be more of a risk of this complication in people with OI. So I guess a final statement is I don't know of any information that treatment with bisphosphonates or others of these bone drugs is good or bad for dentogenesis. So it seems to be pretty neutral.
Thank you. And then we're getting the question about collagen supplements. Are those worthwhile?
In terms of bone, no good evidence to suggest that collagen supplements are important. The issue of protein nutrition is important for bone health. So, for instance, people with malabsorption or vegetarians are a bit challenged to get enough protein, which is important for normal bone metabolism. And collagen supplements or other protein supplements can be important for people that don't get enough protein in their diet otherwise. But specifically, collagen doesn't seem to be particularly effective. Obviously, that's an important question in OI where collagen mutations are at the heart of the disorder.
Thank you. Then another question for anyone is, Is there any data on stroke risk for people with OI? Anybody want to weigh in on that? No? All right, well, let's move on to a couple of questions for Dr. Vernick. Hearing, is there any increase in prevalence of inner ear or balance disturbances with increasing age in OI?
There's certainly an increase. Can you hear me?
Yes.
Okay, there's certainly an increase in progressive hearing loss with OI because of that abnormal bone that I showed you on the slide. It's not clear whether the balance issues that come up with OI are any different than they would from normal aging. If you factor in the other orthopedic types of problems, the cervical spine, the spine type issues that people have, that can affect their balance as well. So I think if you look at it overall, it's probably not a major inner ear deterioration effect from balance from OI, except the normal changes that you get from aging.
All right, and then several people have said talked about a random earache pain that lasts several days without an ear infection, and wondering if that might be connected to inner ear bone loss associated with OI.
I would say that the answer is probably not. I don't see anybody who has significant ear pain from an inner ear problem. Intermittent pain like that in the ear with a normal ear exam is usually some pain referred to the ear from something outside. The most common one is the jaw joint or temporomandibular joint, but things like neck pain, sinus pain, headaches, throat pain, all of those can refer pain to the ear. And so when you see somebody that has ear pain, especially if it's a recurrent type of ear pain, you really need to have a good head and neck examination to make sure that you don't have anything else going on, and try and figure out the source of it, because it's probably not the ear itself.
Does elevation affect hearing loss?
I hope not. Not that I know of.
And one last hearing question. My daughter has always had sensitive hearing and sleep issues due to a high-pitched noise she said she hears when it's quiet. Does this indicate anything related to hearing loss?
It certainly can. There is something called tinnitus, which is a sound that you can hear in your head that nobody else hears, but you can hear it. And it's fairly common, and the older we get, the more common it is. It's estimated that about 20% of the population has it, and over 50, the numbers go up significantly higher than that. It is many times associated with hearing loss, but not always. It can be associated with loud noise exposure, head injuries, ear infections, all kinds of different things can be a trigger. And unfortunately, there isn't a lot to do that actually will make it go away. So treatment usually centers on getting used to it, and most people just adjust to it and ignore it. But if they're having trouble sleeping at night, putting on something like a fan or some music, or there's some nice apps on the phones or the computers that will play like raindrops or the ocean sounds or something that they find soothing, and will tend to mask that out so that people can go back and sleep again.
We have a few orthopedic questions. Let me put them out there and see if anyone wants to take them. Regarding compression fractures, is physical therapy recommended during healing?
Right. So I think that, as long as the physical therapist is aware of what's going on, that's fine. As Dr. Smith pointed out earlier, most of these are not really, the compression fractures are not fractures like we think of with long bone fractures, where those can be not aligned. These compression fractures, as I was showing, they're just kind of a loss of the height of the vertebrae, or give you this kind of wedge-shaped appearance because they're more like a crush. You can kind of think of it like as a crush fracture. And so, I mean, in general, physical therapy should be fine. You know, again, as I mentioned, things like jumping from a height can, you know, cause it. So, you know, you would want to avoid kind of impact sorts of physical activity. But again, kind of stretching or other sorts of routine core strengthening that Dr. Smith was talking about, all those things are safe and fine if you have a vertebral compression fracture.
Oh, hi, Dr. Smith. Welcome back. Thank you. You're a busy man today. We had a couple of ortho questions. One, are chiropractic adjustments possible for OI? Is that beneficial? Oh, we can't hear you. Need to unmute.
There you go.
Thank you.
All right. So, yeah, I just heard out of the corner of my ear the orthopedic, but I didn't.
The question was, is chiropractic adjustments, are they possible for folks with OI, and is it beneficial?
Well, you know, I like to say that chiropractors and orthopedists speak a different language. I mean, a lot of times they talk about, but in reality, a lot of their treatments are effective just as well as orthopedic procedures for pain, as long as they're not trying to tell you, in my experience, that they're changing some fundamental property of your bone. I think that generally they're promoting, like we're promoting, physical activity, strengthening, maybe positioning to relieve different parts of the spine that are causing different kinds of compression. Again, it leads into this a non-operative treatment of back pain. Avoid dramatic treatments or dramatic claims of that someone's going to make you tremendously better, but have someone help you to manage your pain so that you can have a good quality of life. So.
And can running long distance like 5 and 10 Ks lead to compression fractures? And we did just.
I'm not that aware of that. I mean, in general, you have to listen to your body to some extent, but try to push onward. So I think in general there have been individuals who have taught me a lot of, showed me a lot about the things that they can do in terms of sit-ups and push-ups, and there are certainly individuals with OI that own gyms and do a lot of physical activity, more so that in general that supports the bone. I think you have to be a little bit rational about injuries with distance running of your feet and knees and things like that, and listen to your body. But in general, we're promoting physical activity. Yeah.
And I would just like to add just sort of a personal note on something that Dr. Sutton just mentioned about compression fractures, and you talked about them, Dr. Smith and Dr. Germain-Lee. In pregnancy and post childbirth, I found that there is a lot of stress and pressure moving with a new baby, carrying that infant seat and twisting into the car or lifting that baby over into the crib. So I just sort of wanted to point that out as a time to be extra careful, as you all have said. And as another aside, for anyone interested in more information about pregnancy and OI, there's a whole session later this afternoon where I know that topic will be covered a lot. So you may want to tune into that. Let me just see what else. Erica or Danielle, do you have any additional questions that stuck out to you? And I do want to say to everyone, if we don't get to your question, please just feel free to email the foundation at bonelink@oif.org. I know this information is in the chat feature, and they will get answers for you, or if you think of questions later. Let's see.
Carolyn, we're right at time, but I think we have time for maybe one or two more questions. I see one here. Are bisphosphonates also effective for preventing tendon and muscle injuries, or only for bones?
Bisphosphonates are very specific for bone, and they shouldn't have effects either positive or negative on muscle and tendons.
Thank you, Dr. Orwell. Time for one more question. I see one very interested to hear more about transient osteoporosis, not only of the hip, and I might be reading this wrong, but in mainly walking OI adults.
Transient osteoporosis is an unusual and not very well understood disorder. It can just occur out of the blue and last for a variable period of time. Therapy for it is certainly not very well established. I haven't heard of transient osteoporosis being particularly associated with OI, but I would imagine that people with OI could get it. I'm not sure if anybody else has any additional information. Again, an unusual and not very well understood disorder.
Thank you for the insight. Very interesting. So I think we're at time, and I just want to thank everyone, our speakers, for great talks, and thank you, Carolyn, for moderating so beautifully.
Thank you, Erica and Danielle at the OI Foundation for organizing and running the session. Thank you all.
Thank you. We have 3 sessions coming up. We hope you'll join us for. We have the Youth Forum, the Women's Health Forum, as Carolyn mentioned, and then also our dental session. And you can find all of those on our website, oif.org/virtual conference. Thank you, everyone.
Can I just add one quick thing? A little plug for the OI registry. Really would hope everybody would go on and make sure they're signed up. It's a great way for you to get more questions answered, and with your questions help sort of drive and steer our research. If you feel like you've signed up for that in the past, I'd like to ask you to go in and do it again. Technology has changed over the years, and this particular registry is going to allow you to get feedback. And then also, I want you to know that Erica and Danielle and the folks at the foundation have done such an incredible job of putting fact sheets and information on the OI website, which are super helpful to print out and take into your doctors. So be sure and check out the website and the podcasts and YouTube channel that they've put together. So thank you all again for joining us.
Thank you. Goodbye.
Bye.